Good morning, everybody. सुन नहीं रहे हो सब
Good
जना?
morning, sir.
Yeah.
Howdy, sir.
Okay, today we are going to start a topic on pneumonia, also acute respiratory tract infection. So pneumonia, as you know, it's very common. The highest cause of one of the highest cause of mortality in children below 5 years of age. Because below 5 years of age, the immunoglobulin like IgG is not well developed in children. So they are more prone to infections. And a lot of other factors are also there. One of the most common factor is due to decreased level of immunoglobulin G, IgG. The pneumonia is a leading cause of mortality and a common cause of morbidity in children below 5 years of age. Kills nearly 3 million children every year in developing countries. So 10 times higher cause of incidence of pneumonia is there in children in developing countries compared to the developed country. 10 times more common in developing countries like Nepal, India, Bangladesh compared to Western countries. It's responsible for 19% of all death in children below 5 years of age. WHO classification of ARI. Basically, this WHO classification of ARI to detect pneumonia mostly in developing countries and mostly in the remote places in Nepal, where all the facilities are not available and doctors are also not available in most of the remote villages in Nepal. So basically, it is for the paramedical staff as well as for the junior doctors, where the facility is not available. So how will you classify the pneumonia according to WHO? Depend upon the symptoms and signs classified, and after classification, we give the treatment and where to treat, at home or in the hospital. So according to that has been classified in developing countries by WHO to find out the pneumonia or acute respiratory tract infection. The child is having cough and cold, but there is no fast breathing, no chest indrawing, or indicators of severe illness. There is only cough and cold, but child is not having any tachypnea or dyspnea. There is no any chest indrawing and severe illness. Like if there is no a very high grade fever, child is not looking toxic. It is classified as no pneumonia, mostly upper respiratory tract infection. So you can treat the child at home with home remedies, a lot of soup, and you can give if the child is more than 6 months of age, you can give the steam inhalation. And very low grade fever is there, you can give paracetamol, 10 to 15 mg per kg per day. And if the child is above 2 years of age, you can give some antihistaminic like fexofenadine, and you can manage at home. Or keep the child warm. Okay, that way you can manage at home. And according to the respiratory rate, the tachypnea is defined as the respiratory rate is 60 or more in less than 2 months of age. That is tachypnea. So below 2 months of age, from birth up to 2 months of age, the respiratory rate should be below 60. 60 or more, that is tachypnea. Tachypnea, according to WHO, maybe other causes are also there, but if the signs of cough and fever is there, you have to think of pneumonia. If the infant is 2 months to 12 months of age, and if the respiratory rate is 50 or more, that is tachypnea. The child age is 12 months, 1 to 5 years, 12 months to 16 months. The respiratory rate is 40 or more, that is tachypnea. Tachypnea is there with cough. You have to classify it as pneumonia, and you can treat the child with cotrimoxazole, amoxicillin. Cotrimoxazole dose is around 6 to 8 mg per kg per day in 2 divided doses for 7 to 10 days, and you can manage at home. Amoxicillin dose is around 40 to 60 mg per kg per day. Depending upon the severity of symptoms, you can adjust the dose. If the child is having severe symptoms, you can start with 60 mg per kg per day or around 40 to 60 mg per kg per day in 3 divided doses for 7 to 10 days. Depending upon the improvement, you can treat at home. The child is having cough, child is having fast breathing like tachypnea, according to the respiratory rate below up to 2 months, 2 months to 12 months, and 12 months to 16 months. It is above that range. That is tachypnea. The child is having cough, child is having tachypnea. There is chest indrawing is there, but there is no central cyanosis. And if the child is able to drink, and you term as severe pneumonia, in severe pneumonia, you have to always manage at home. Always manage in the hospital with the IV antibiotics like penicillin. After test dose, you have to give the penicillin. Penicillin dose is 50,000 unit per kg per dose every 6 hourly for 7 to 10 days, depending upon the improvement. So in severe pneumonia is there, you have to manage the child at hospital. Other one is if the child is having cough, fast breathing, chest indrawing. Chest indrawing is very severe, and there is central cyanosis, inability to breathe, inability to drink, and it is formed as very severe pneumonia, and you have to manage in the hospital with IV chloramphenicol around 75 mg per kg per day, 8 hourly for 7 to 10 days. So this is the classification according to WHO. WHO has classified to simplify pneumonia basically in developing countries to cover all the remote villages where the hospital facilities are not up to the mark. Sick child, if the child stops feeding, if the infant is below 2 months of age, if the stop feeding, if there is convulsion, abnormally sleepy or difficult to wake up, the infant is having wheezing, stridor, the fever is there, the fast breathing is there, the severe chest indrawing is there, there is central cyanosis, the child is grunting, apneic episode is there. Apnea is defined as cessation of respiration more than 20 seconds, or if it is less than 20 seconds, it's associated with cyanosis and bradycardia. The distension of abdomen is there. These all symptoms and signs of severe illness. Basically in below 2 months of age. Now, come to the topic of pneumonia. Pneumonia is defined as inflammation of the parenchyma of the lungs. It is inflammation of the parenchyma of the lungs. It is defined as pneumonia. What are the risk factors for pneumonia? The baby is born below expected birth weight. The baby is having low birth weight, below 2,500 grams. 2.5 kg भन्दा मुनि छ भने that is low birth weight. The baby is having malnutrition. There is a lack of breastfeeding. One of the study has shown that those baby who are breastfed, they have less chance, 5 times less chance of having pneumonia compared to the breastfeeding. That means compared to the not breastfeeding babies, if those babies are breastfed, they have less than 5%, means less than 5 times of having pneumonia compared to non-breastfed baby. There is having underlying lung disease like asthma or 65 disease, they are more prone to pneumonia. There is an anatomical problem like tracheoesophageal fistula is there, high chance of having pneumonia. Gastroesophageal reflux disease, GERD, mostly associated with aspiration pneumonia. The child is having any neurological disorder that interfere with the production of the airways. Less gag reflex will be there, having more chance of aspiration pneumonia is there. Disease that alter the immune system like immunodeficiency, combined immunodeficiency, or if there is any child is having IgG, IgM, IgA, IgE deficiency, or hyper Ig means if the immunoglobulin M is very high, so those children are more prone to having pneumonia. Other like complement deficiency, phagocytosis deficiency, T cell defect, these all comes under the immunodeficiency. Primary immunodeficiency, they have high chances of having pneumonia. Secondary immunodeficiency, the child is having HIV, the child is having any malignancy, the child is on prolonged use of steroids. So those children are also having acquired immunodeficiency, chances of pneumonia is there. What are the etiological agent of pneumonia? So etiological agent of pneumonia more commonly like respiratory syncytial virus, parainfluenza virus, influenza virus, adenovirus. Now, not written here now, we are facing a coronavirus infection. So now we can write on coronavirus pneumonia. Okay. So these are the viral etiological agent who can cause pneumonia. Bacterial cause of pneumonia like Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenza type B, group A, Streptococcus, gram-positive organism, as well as the gram-negative organism like E. coli, Klebsiella. So these they cause pneumonia basically in newborn below 2 months of age. A typical organism like chlamydia pneumoniae, mycoplasma pneumoniae, they are the atypical organism which can cause pneumonia. In immunodeficiency state like HIV patient, pneumocystic enterovecai can cause pneumonia. Fungal pneumonia like aspergillosis, histoplasmosis, coccidioidomycosis. Basically, these cause pneumonia. Aspergillosis more common in immunodeficiency patient or children with cystic fibrosis or asthmatic children. Chances of having aspergillosis pneumonia. So ecological agent like gram-positive organism, gram-negative organism like E. coli, Klebsiella, atypical organisms, Mycoplasma pneumoniae, Chlamydia pneumoniae, and I have not written one of the bacteria like Mycobacterium tuberculosis. It also causes pneumonia. It's very common in Nepal. Pathology of pneumonia. There are four distinct phases of pneumonia is there. Number one is the stage of congestion. So it will start from day one, last up to second day, stage of congestion. The presence of bacteria in the alveoli, bacteria or fungi or viruses in the alveoli, they cause vasodilatation. There will be outpouring of edema fluid into the alveoli. The stage of congestion. Now, second one is the red hepatization. From the second day to fourth day, there is a stage of red hepatization. But there will be alveoli contain leukocytes and red blood cells. Lobe is dry and solid and granular. One is the gray hepatization from 4 days up to the 8 days. So affected lung is solid, grayish in color. And last one is the stage of resolution, day 8 to 9. There will be inflammation process there that will subside, and macrophages remove the cellular and bacterial debris. And fibrin deposition is seen in the pleural surfaces. What is the pathogenesis of pneumonia? In viral pneumonia, there will be direct injury to the respiratory epithelium, resulting in airway obstruction from the swelling due to abnormal secretion and deposition of the cellular debris. So, in viral pneumonia, direct injury to the respiratory epithelium, which result in airway obstruction. Airway obstruction occurs due to swelling, due to edema, abnormal secretions, and deposition of the cellular debris. Pneumococcal pneumonia produces local edema that aids in the proliferation of organisms spread into the adjacent portion of the lungs, result in focal lobar involvement. In pneumococcal pneumonia, it's a lobar type of pneumonia. One single lobe will be involved. There will be a solidification of the one lobe. Group B streptococcus pneumonia, it's a more diffuse interstitial type of pneumonia. More of the interstitium will be involved in group A streptococcus pneumonia. Staphylococcus aureus pneumonia, there will be confluent bronchopneumonia. So there will be initially it will be the patchy involvement of two or more site in the lungs. Usually it's unilateral, in the unilateral, but there will be two or more site will be involved, like a bronchopneumonia, and later it cause area of hemorrhagic necrosis, and then followed by cavitation of the lung parenchyma, result in pneumatocysts. These pneumatocysts can rupture and can cause pneumothorax. There is pneumatocyst cyst filled with the air and fluid. So that is more commonly seen in Staphylococcus aureus pneumonia. Sometimes in Klebsiella pneumonia also you can see the pneumatocysts. In Mycoplasma pneumonia, it inhibits the ciliary reaction, and there will be cellular destruction and inflammation of the submucosa will be there. Clinical manifestation of the pneumonia. In case of viral pneumonia, there will be low-grade fever. Most of the viral pneumonia, some viral infection, like in coronavirus, there will be high-grade fever. Mostly in most of the bacterial pneumonia, there will be high-grade fever. Child will be more of toxic. There will cough will be there. The child is old enough, you can expectorate out the sputum. So maybe rusty, apple green, or mucopurulent. Rusty sputum you see in the pneumococcal pneumonia. Other pneumonia, like initially there will be Klebsiella, there will be greenish color sputum, apple green color of sputum will be there. Staphylococcus, maybe mucopurulent, purulent type of sputum will be there. The child is old enough, they can complain of chest pain, anorexia. Sometimes if the basal pneumonia is there, the lower lobe at the base of the pneumonia is the base of the lung. If there is pneumonia, it can cause referred pain to the abdomen, and there will be some symptoms of vomiting, diarrhea, mimic like an acute abdomen. But you have to always rule out pneumonia. The child is having cough, high-grade fever. Don't only stick with the acute abdominal condition. Sometimes it mimic like acute abdomen, but it may be a pneumonia, basal pneumonia. And signs-wise, there will be fever will be there, child will having tachypnea, child will have grunting, there will be use of accessory muscles of respiration, flaring of LNAJ, intercostal subcostal retraction will be there. If you don't treat, or if it is progress, it can lead to EQ mismatch and can cause cyanosis, central cyanosis will be there. If you auscultate, you can find the scattered crackles, wheezing. There is a consolidation is there, underlying consolidation. You can auscultate, you can find the bronchial breath sound. And if upper lobe is involved, it can mimic sometimes like a meningitis, knuckle rigidity. Investigation-wise, you do the complete blood count, see the white blood cell count, usually with neutrophilia, usually seen in bacterial pneumonia. Count will be as high as more than 20,000, and more of granulocyte predominance will be there. So neutrophilia will be there. In viral pneumonia, count may be normal, sometimes it may be low, rarely it increase, and more of lymphocytes will be there. And in every case of pneumonia, you do the blood culture. If child is well enough to take out the sputum, you can do for the gram stain. And depending upon what you are thinking, causative organism, you can send for viral marker or do the fungal staining. And always do the culture and sensitivity of the blood as well as the sputum. Serological marker basically you do for the viral infection. In severe pneumonia, you do the arterial blood gas analysis, see there is respiratory acidosis is there or not, and type 1 respiratory failure, type 2 respiratory failure, hypoxia, partial pressure of oxygen may be low, or type 2 respiratory failure where there will be partial pressure of oxygen will be low as well as the PCO2, partial pressure of carbon dioxide will increase. That is type 2 respiratory failure. So you have to detect whether child is having normal partial pressure of oxygen, normal PCO2, or child is having type 1 respiratory failure or type 2 respiratory failure. Let's do the chest X-ray. Viral pneumonia, mostly hyperinflation with bilateral interstitial infiltrate and peribronchial coughing you will find on the chest X-ray. Bacterial pneumonia, mostly pneumococcal pneumonia, there will be the lobar consolidation will be there, one single lobe is involved. Atypical pneumonia like pneumonia due to mycoplasma, chlamydia, will be poorly defined hazy or floppy shadow, the exudate radiating from the hilar region will be there. Sometimes it mimic like a hilar adenopathy. Hilar prominence also you can see in the Mycobacterium tuberculosis. And rarely you see the consolidation in case of atypical pneumonia. Treatment wise, if the child is below 3 months of age, always you have to admit. If above 3 months of age, depending on the severity, the child is a moderate to severe respiratory stress, you have to admit in the hospital. Keep the child NPO nil per oral, start IV intravenous fluid, 1/5 or half nose line with 5% dextrose. Later you can add the potassium chloride, the maintenance dose. And if see the oxygen saturation, if below 92 or below 92%, start the oxygen supplementation, 0.5, depending on the saturation, you can increase 1, 2, 3 liter per minute. For fever, give paracetamol, like antipyretic paracetamol. Dose is 10 to 15 mg per kg per day in 6 hourly. Antibiotic, if you are suspecting pneumococcal pneumonia, give penicillin. Dose is 50,000 units per kg per dose every 6 hourly for 7 to 10 days, depending on the improvement. Staphylococcal pneumonia, penicillin or cloxacillin, the drug of choice. Penicillin dose is same. Cloxacillin is 50 to 100 mg per kg per day in 4 divided doses for 7 to 10 days. Haemophilus influenza, ampicillin or chloramphenicol. Ampicillin IV dose is 50 to 100 mg per kg per day for 6 hourly for 7 to 10 days. Chloramphenicol around 75 mg per kg per day in 3 divided doses, 7 to 10 days. Atypical pneumonia, erythromycin around 40 mg per kg per day in 4 divided doses, 7 to 10 around for 7 days. Azithromycin 10 mg per kg per day for 5 days or 10 mg per kg day 1, then followed by 5 mg per kg for 4 days. Gram-negative organism, cefotaxime, ceftriaxone, amikacin, gentamicin. Cefotaxime dose is 150 mg per kg per day in 3 divided doses for 7 to 10 days. Ceftriaxone is 75 mg per kg per day in 2 divided doses. If the large pneumatocyst is there, sometimes pneumothorax is there, you can put the intercostal tube and drain the air. Sometimes there is empyema or empyema, you have to put the intercostal tube underwater shield to drain the pus, fluid or air. And if the child is not improving, If the child develops type 2 respiratory failure, so sometimes you have to intubate the child and put on the mechanical ventilator. Complication like parapneumonic effusion. If you don't treat the pneumonia, they may have parapneumonic effusion and develop into pleural effusion, empyema, collection of pus in the pleural cavity. There may be retention of sputum, can cause collapse of the lungs, may develop pneumothorax, suppurative pneumonia, lung abscess, pericarditis, myocarditis, extrapulmonary complication like pericarditis, myocarditis, pulmonary complication like adult respiratory distress syndrome, ARDS, extrapulmonary complications like renal failure, multi-organ failure, septicemia, meningitis, suppurative arthritis, osteomyelitis. These are the complications of the pneumonia. So I have covered